So very briefly, the reason why we put on this webinar this evening is to give you a bit of an idea of what Dr. Barry Glassman was going to be speaking about when he comes across in the UK this June. We've sponsored Barry's seminars for the last 8 years. He came across first in 2011 at the Royal College of Physicians, where we had 170 odd delegates come along to that course where we talked about occlusion and occluding and some myth busting theories and discussions we had. So it was a fantastic time. Barry's come back every year since. We love having him across, and this year we're very excited to have him at our premises in Sheffield on the 21st of June. And then we're going to see him down in London on the 27th and the 28th of June. The 27th is a theory session, and the 28th being a hands-on session. So people that attend the day one often return to day two to come and do the hands-on session, where we do lots of stuff and patient exams and patient discussions, and then actually fit some splints as well. Barry's probably going to explain a bit more about that this evening as well. As I say, if you've got any burning questions, drop us a quick question in the answer box. I'm going to be moderating the session along with Maddie, who's on our marketing team at S4S. We can interrupt the session again if you do have any burning questions that need answering. Otherwise, we'll take questions at the end. The other thing as well, following on from this, we are recording the session, so we can send out a recording of the session afterwards for you to view and look back on. And we're also going to be sending you, as a thank you for attending this evening, a discount code for the seminars in June. We'd love to have you there. I'm going to come and say goodbye to you all at the end. So without further ado, I'll introduce you to Dr. Barry Glassman. Thank you, Barry. Can you hear us all right, Barry?
I can, Matt. Thanks a lot. I appreciate it. And thank you all for attending and spending a quick hour to what I hope will be, in the long run, a major change and provide a major plus for you and your practices. I've been teaching for as many of you may know, for many years, and went through what I consider to be a rather torturous path to get to the point where my goal was to begin to help as many patients as I could in terms of joint dysfunction and orofacial pain, and moved my practice solely to treating orofacial pain and joint dysfunction as well as sleep disorders. And in that discovery, in that torturous path, what I came to realize is that so much of what we were taught in dentistry about occlusion was mythical and not valid, and that so much has been done to create a rather difficult path for us, hoops, so to speak, for us to jump through in order to appropriately treat our patients. And a lot of the information we have is based on some concepts of confirmation bias, and this concept of so much of what we know just isn't true. And if we can break through and unlearn some of that, and then relearn the reality of when occlusion matters, why it matters, then we put ourselves as general dentists in a fantastic position. I kind of jokingly labeled this session why night guards suck, and it's not like me to do that, but the realization has come to us that so much of what we do with night guards makes no sense. And so much of the concepts of bruxism, parafunction, and occlusion, when we really look at the preponderance of the evidence, when we go to the evidence-based issues and we discuss that, it really forces us to change. And what I've learned is that it puts us in a position to so much better help our patients than we ever could possibly imagine. That's our goal. I've noticed, and I think you've probably noticed this as well, that there's more and more attention to, and time being given to online learning, online courses. And I appreciate that. I appreciate how difficult it is to find time and get somewhere and go and travel and devote an entire weekend. In fact, I got a little tired of doing that and finding out so much of what I was being taught either wasn't true or wasn't implementable or what wasn't, in some way, shape, or form wasn't valid. And it becomes its own game, what I call the CE game. I have worked very, very hard to make sure that anyone who takes the time to come see us isn't caught in that CE game. And my goal when you come to see us, either in Sheffield or in London, is that it's truly applicable, valid information that, and excuse the expression, on Monday morning, you'll truly be able to go back and really make a difference to that patient who asked you about their clicking, or asked you about their joint pain, or can't bring their teeth together properly, or says something to you like, Dr. Tan, may I ask you, can you help me? My bite's just not comfortable, or I have two places to bite, or it's just a little high here. Can you just adjust that here? All the answers that we now have to those questions may not be the best answers in our best interest, in our patient's best interest, and our goal is to give you those answers. The next question is how do we check occlusion, and why we say you should never ask a patient if they grind or clench, or we should never ask a patient if the new bite is comfortable. And in the long run, in the short run, that may seem unnecessary. In the long run, it's incredibly helpful. And why? The answers to all these questions are what we cover. This is one of my favorite sayings. It's from Toffler, the illiterate of the 21st century. Won't be those who can't read and write, but those who can't learn, unlearn, and relearn. We're smart people, darn it. We're real smart people. We graduated dental school and had lots of options. We chose a profession that could help other people. We chose a profession that can give us a decent lifestyle. We chose a profession that would give us the opportunity to think. And unfortunately, it's my humble opinion that dental school takes us intelligent people who are capable of complex thinking and turns us into linear thinkers. And we start asking questions like, where's my checklist? What burr do I use? And frankly, silly questions when there's so much that we can do. What blew me away when I had gone through many years of craziness, from taking the condyle after studying with Niles Goucher and shoving it back into a reproducible position, and recognizing and adjusting the bite for that position, recognizing that there were better ways to resolve patient's pain or dysfunction, and then bringing the jaw forward, working with Harold Gelb for many years, and realizing that there were better ways to bring the jaw forward, and then working with the neuromuscular team for many years, and realizing that there were better ways to help our patients, and then suddenly coming up with the understanding why things get that way and how they stay that way, and how important power function is as compared to function, and looking at that closely and realizing that we as dentists aren't even taught very well how we masticate. And if we talk about masticatory generator cycles, or we talk about masticatory cycles, or the role of teeth during mastication. I recognized my education was so limited when it came to that, and it didn't seem to matter. It didn't seem all that important. But when you put it in perspective, it really can matter, and because it can help us really begin to understand the role of occlusion in each and every patient we see. and how we can help them and how we can prevent them from getting into some of the troubles that we see. So unlearning some of the basic concepts and then relearning has become is a major purpose of the course. I'm having trouble with, there we go. Sorry about that. Despite the science, disconnecting occlusion and pain, TMD camps have formed and continue to battle, and the battle doesn't help anybody. The battle is crazy. The neuromuscular people hate the nathology people. The nathology people hate the altered joint position people. And the reality is that you and I have been doing dentistry for a long time, and we recognized in our own way that joint position can't really be as important as people think it is, because we do so much in our office without ever knowing what position the condyle is at any given time. And with that in mind, we've looked closely into why that was, and we go into that deeply. There's a lot of discussion about TMD, and I want to make it clear that our course is not specifically designed to teach how to treat all of the advanced issues in terms of orofacial pain, to recognize them surely, to become the general dentist that we should be, to be able to treat the basics the way a physician can treat the basics when it comes to hypertension. And then when it's time, if there's a significant cardiovascular disorders, they send them to the right people to treat the cardiovascular disorders. We never got there in dentistry because of all of the conflict and the confusion. We never got to the point where we could really make good decisions and help people at the base level. Well, what I learned was that this base level of treatment of parafunctional control was so incredibly effective that many of the patients that came to me as a quote unquote specialist, we wound up doing parafunctional control, had these long treatment plans because of all these, the reality of all the specific diagnoses, not TMD, but whether it was splenius capitis muscle disorder, or whether it was an orofacial pain pattern, or neuropathic pain pattern, whether it was trigeminal trigeminal neuropathy of some sort, or trigeminal neuralgia, or even when it gets into the headache diagnoses of migraine or tension type headaches, etc., cervicogenic headaches, all of those things. What we found was that when we did appropriate parafunctional control, all the treatment planning that we were planning to do became unnecessary. So it struck us that wouldn't it make sense that the general dentist could do this parafunctional control in the name of protecting the teeth without treating the TMD, so to speak, and many of the symptoms of the joint dysfunction or orofacial pain often got resolved. And then if it didn't, just like the physician who can give the basic medications for hypertension, and then for more advanced cases, send it on to someone else. What does the answer that often becomes, well, if I've got a patient that grinds or clenches, or I've got a TMD case, I'm going to give them a night guard. And I ask very simply, what does a night guard do? So if you accept the fact, which has been shown by Lobozo and others, that parafunctional activity tends to be centrally mediated. So when we look back at Ranford Nash in 1961, when it was suggested that the goal of parafunction was to eliminate these little white spots on the teeth interferences, that somehow the body knew was there. Well, none of the evidence ever suggested that that was valid. So we're constantly looking for, why do teeth grind, or the muscles all of a sudden contract at night, when we know as we go deeper into sleep, the musculature becomes more and more relaxed. And we go deeply into this during our course, and it's absolutely fascinating. There's actually, we'll make reference to an Avanchar study that demonstrated parafunctional activity in a neonatal frog, which may explain some of the function of this disorder that's left over. So our goal really became, let's accept the fact that we don't know the cause. Yes, we know that stress may be involved, and you and I can do our best to help our patients with stress levels, but I think we're better off dealing with our own, but that's another issue. We know therefore that while it makes sense and it seems to be the logical thing, let's get at the cause, sometimes the causes aren't able to be approached because they're not known. And now we have to deal with the forces as a result of that. And when we put what we know for sure is that what we were taught in dental school is not accurate. We were taught in dental school that the first 20 millimeters was pure rotation. Do you remember that? Well, it's not. As soon as we begin to open, we rotate and we translate at the same time. I'm not sure why that matters so much, except it does matter that when we put something between the teeth, the condyle is now out of its safe harbor, putting a strain on the lateral collateral ligament, the medial collateral ligament, the retrodiscal lamina, etc. And now parafunctional forces actually tend to put it more at risk. So if we put a night guard in, and it doesn't, and it actually potentially increases the EMG levels, which we know it does, and that condyle is out of its safe harbor, we have the potential to make a patient, make a patient worse, or put them at greater risk for an intracapsular disorder, even if they didn't have one before. Now, you and I both know also that sometimes we put a patient in a night guard and they get better. Why? Well, we can explain that. We can talk about how they get better and why they get better in spite of this. Now, the question is, how can we put our patients in the best position to most likely improve whatever their specific condition is? And what we're going to find out is that in almost all, not all, in most cases, it's not going to be the night guard that is commonly made in dentistry. We know that it can increase these potentially harmful parafunctional forces. We know that Gagnon did a recent study that showed that a maxillary study has the potential to increase the AHI of more obstructions in a sleep obstructive disorder. We can talk about that. I think that may be overstated and not a reason not to do a maxillary night guard, but we can explain that. So when we look at the structures of the craniomandibular system, we look at all of them. So we need to look at the teeth, the ligaments, the joints, the bones. We'll go over these literally in detail and begin to talk about the adaptive capacity of each one of them and help understand why it is that sometimes some people brux their teeth and they have joint pain and you don't see anything anywhere on their teeth, or they don't have any muscle pain. And other people brux their teeth and their teeth are worn down to nothing and their joints feel great. Well, wouldn't it be great for us to understand that and use this information along with what the patient's desires are, as well as what the potential of, once we understand the forces in terms of the direction in this case, as well as the magnitude, what the long term would be, and we can discuss fairly and appropriately with our patients. This is what we have. This is where this may go, and whether any prevention or treatment is required, and how it is that you would treat your wife or your daughter or your husband if they presented with what your patient's presenting in a logical fashion. No mama drama. Not talking about prevention unnecessarily, not talking about treatment unnecessarily. And the goal is to provide a treatment that's reversible and that makes the most sense so that whatever is causing this destruction, whether it be slow, whether it be chronic, whether it be acute, whatever is causing it, we can control the forces that are leading to this problem that would then therefore allow some healing to occur. So we're going to look at the teeth, the joints, the muscles, the ligaments, the bones, and then spend some time on understanding the trigeminal system. Then this gets a little disconcerting to some because it sounds like we're going to go deeply into anatomy and physiology, and it's not that it's a deep dive, but it is a thorough dive. So we'll talk about the mesencephalic nucleus and what role it plays, and nucleus caudalis and what role it plays, and you'll understand trigeminal neuralgia, and you'll understand the difference between that and many of the differential diagnoses in terms of oral facial pain. Yes, we do cover that briefly, but more importantly, we cover the things that you see on a daily basis every day. We talked about the fact that translation doesn't occur, and that's what this slide is referring to, that it doesn't occur, rotation doesn't occur by itself, and then it occurs in combination with translation. This doesn't really affect any of us. The people that get upset by this are those that are attempting to get at or talk about the importance of CR, and we'll spend a lot of time talking about CR, what role it plays, and where we personally believe it's a bit overstated in terms of health. Certainly not overstated in terms of reproducibility that's required and helpful as a dentist when you're doing restorative care. So that there's no pure rotation, and that's been discovered. These are EMGs of actually, it was an orthodontist who attended one of our classes and was having some joint discomfort and had just come back from a major guru here in the States class where he had his specialized appliance, full arch Tanner type appliance that was constructed for use at night. And here he is clenching on his natural teeth, and we're getting EMGs of 64, 51 on temporalis, and 41 and 38 on the masseter. And then when we had him put his appliance in, we see a significant increase in EMGs. This does not mean that therefore wearing this appliance will make him worse. That's not what this means, but it does mean that the forces in terms of the magnitude are greater. So if the forces are greater in terms of magnitude, why won't it make him worse? Well, it depends on what his problems were in the beginning, and if this appliance leads to an alteration in the direction of these forces, even though they're greater, his symptoms may improve. This helps us understand why appliances and how appliances work. And once we understand why and how they work, then the responses that we get to them are so much less confusing. And we'll stop arguing about things that don't matter. Was it an upper? Was it a lower? Was the patient in CR? Was it, there are many factors that may be important in that case or may not be important in that case. Wouldn't it be great to know all those factors? To be able to look at an appliance and get a feel for whether that's the right appliance for that patient. What we do know is this, is that when we look at all the forces in the system, that system that's made to function in the absence of dysfunction and pain, and we have either dysfunction or pain, then the forces in the system have begun to destroy something, whether the forces are too great or the adaptive capacity of that particular structure is too small, whether it be genetic or whether it be because of repetitive activity, microtrauma, or whether it be because of macrotrauma. So we're looking at analyzing the system, each of the components individually, and then analyzing the forces and determining when it is they're likely to do damage. And here's the good news. The good news is that parafunctional forces are much greater than functional forces. And that oftentimes it's not the functional forces, it's not eating, talking, walking down the street, kissing your spouse. Those are the chewing gum even. These are not, for many patients, not the forces that tend to cause the problem. Once the ankle is sprained, so to speak, now the normal walking may be problematic. So when we're looking at sprains and strains of the joint, our goal is to find out how to get that way. And then how can we create an environment that will allow God or Darwin, and I don't want to get into that argument, but allow the body to heal? Because frankly, we do a better job of that than we do of healing itself. Our goal is to look and see how things got that way and why they stay that way. So we want to provide a greater understanding of the reality of occlusion. A lot of, it's true. A lot of people, Matt, you know this is true. A lot of people who hear briefly either what I write or what I've said easily misinterpret this because of their own, because maybe I don't say it well, and maybe it's what they're hearing. But what people hear is that I've said occlusion doesn't matter. And I mean, how silly can it be? It cannot be. Of course, we know that if we place a restoration and leave it high, there is a chance, there's a possibility. It's not definitive. You and I both know that we've left fillings a little high and patients have responded without difficulty. We also know that there are certain patients that if you leave it just a little high, you know damn well they're going to respond with difficulty. So if they're going to respond with difficulty, with pain or dysfunction, how can anyone say occlusion doesn't matter? Of course it matters. But what I'm suggesting is occlusion only matters when you're occluding. So we begin to start separating the noun from the verb, the noun of occlusion, and start discussing about how we as dentists tend to stipulate occlusion when in fact we know that teeth were only in some dental contact about 20 minutes in a 24-hour period. So that's not MIP, mind you. That's just some dental contact. So some of the assumptions about dental contact are just invalid. And it's so much better to put that in perspective. We kind of have occlusion out of perspective, and we give that bad perspective to our patients. So we'll talk at length about occlusal dysesthesia, about the occlusal neurotics in your office, the ones that are hyper aware of their occlusion and their bite, the problems that can lead to, the fact how much difficult they are to deal with, and how to deal with them. But more than that, more than how to deal with them, how to help them lose that hypersensitivity, that hyper awareness of their occlusal state. So we want to encourage further learning and complex thinking and begin to get rid of these myths. We also talk a lot about the science, and you'll be given untold amount of literature that for you to read. What you read is up to you, but we'll talk about how to read that literature, what it means, how to find it, and most importantly, how to apply it. Our goal, if there's anything, is to begin to add the word when we talk about occlusion. This patient has an anterior open bite, when. Patient has a crossbite, when. So as I'm walking down the street, if we look at this crossbite, we'll say, oh, look at this, you can see that crossbite. And the question is, can that crossbite cause pain? And the key is, when is that patient in crossbite? Now, I want you to just do me a favor. See, just take a look at that picture. Take a look at it. Tell you to answer yourself, what do you see when you look at that picture? What do you see? No. Okay, I see a crown on the mandibular right. So what? I see the fact that this is me. So I see the fact that I didn't floss well that night. That just saying. But I get that. All right. What's my point, Glassman? What are you trying to say? Do you see anything weird about that picture? Do you? And the answer is no, not really. That's a typical picture we see. Ask me what I see that's weird. And what will I tell you? Why is in that picture am I contracting my masseter and my temporalis? Why are my teeth together? We don't see that as weird. Every picture you see in a book has that picture. Every time you go to a course and there's a picture, every time you take a picture of someone's teeth, that's what, close, that's what we do. That's how we think. But the reality is that's not a functional position. That's a lot to try to get to in an hour. Trust me, that thought process doesn't go away easily. If my goal over when I come across the pond is to spend time to help us understand more about this position, when it occurs, why it shouldn't occur, and what happens when we think and stipulate occlusion. What we don't know makes us uncomfortable. And so the reality is when it comes to facial pain and dysfunction, there isn't as much known as we pretend there is. What dentistry has done is it's taken orofacial pain and joint dysfunction and all the things that we see, and I'm not talking about the kinds of things that I necessarily see in my practice, the kinds of things that you see in your practice every day. And when all the information wasn't available, when things weren't known, what dentistry did was it made it up. And it made it up from the dental aspect. It's almost as though the teeth had to be responsible, were the king of the system, and had to be responsible for everything that happens in the cranial-mandibular vertebral system. Everything. We look at the teeth first and blame the teeth for everything. The reality is that sometimes we've adjusted those teeth, gotten rid of those, whatever those discomforts are, and then assumed, whoa, it was the teeth. See? The teeth did cause that. We need to get out of that. We need to understand what role the occlusion and occluding and teeth actually play in all of that, and need to put those teeth into perspective. And understand that there are some things that aren't known. So what I just gave was an example of a significant example of confirmation bias. And much of what is known is ignored because it didn't agree with the concepts that were developed that made everything dentally oriented. We as dentists can perform tremendous help to our patient. We can do tremendous things. And we can do them easier than we've been taught in the past. So what do we know about occlusion, or do we? And I often think of, and you know, being from the States, the last thing I wanted to talk about is politics. It's almost embarrassing to be where we are. But at the same time, Reagan did make a comment that I think is really, really relevant to us as dentists. And it could have been anybody. It could have been someone talking about the Republicans. In this case, it was Reagan talking about the Democrats. And Reagan said, the problem with Democrats isn't that they're stupid. It's just that they know so much that isn't true. And the problem with dentists isn't that we're stupid. It's just that we know so much that isn't true. And at the end, we'll talk about some of those very things. And once we can begin to understand what it is that is known and what it is that isn't known, we can stop making things up in order to fill in the gaps. Education is the ability to listen to almost everything without losing your temper or self-confidence. It's harder. It's hard to accept that some of the things that we believed were true may not be as accurate as we thought. So this gets to a discussion then of evidence-based medicine and evidence-based dentistry. And oftentimes, SACIT is misinterpreted and misunderstood. It's as though evidence-based dentistry suggests that we need to have evidence to do anything or everything. And without it, we can't. It's inappropriate to practice. And that's not what SACIT was talking about when he talked about evidence-based medicine. He actually was talking about using the science in combination with our clinical experience. Unfortunately, much of dentistry doesn't or ignores the science, and science and practice in the absence of science is voodoo. And yet those who the knee-jerk reaction says, oh no, you have to do everything and only follow the science. Well, then you become actually handcuffed, because doing really good science, working really good studies, for example, even with any appliance therapy, is really, really difficult, and we'll go over and explain that. Yet we do have really good science to demonstrate what anterior midpoint stop appliances provide in terms of forces, magnitude, and direction. And we really have really good science on when patients occlude and how occlusion plays a role in function as well as parafunction. So we need to use the science to guide our art, and therefore look and provide the best conservative, reversible care for our patients that we possibly can. This is from the Dawson Academy, and he has this all in his book and in much of the literature, and it says, "Are you doing good dentistry?" And that's suggesting that all good dentistry starts with the temporomandibular joint. Now, boy, if there isn't anything to make you feel guilty about doing good dentistry, because I don't even. How do you start with the temporomandibular joint? What do you do to the joint? What do they suggest you do to the joint? How does one deal with the joint? Do things really start there, or is this a circular system with no real starting place, where all the factors can influence the other factors in sometimes very difficult to analyze ways? I propose that's the case, and that I trust me that you're doing really good dentistry without starting at the joint. There's a list of things that we know about occlusion, and it's interesting. Engel's classification being critical. Well, 1901 is when Engel came up with this classification, and it was never done with any science, and there is no evidence that a class 1 occlusion is any more less likely to develop pain or dysfunction than a class 2 or class 3. We'll talk about slides and interferences and vertical dimension and deep bites. The suggestion is that causes retrodiscal compression, and we'll show you why that isn't always the case. And in fact, retrodiscal compression very rarely causes the joint pain that we see. The good news is much of the joint pain or joint discomfort is some sprain or strain that can be readily resolved in your general dental office. Malocclusion causes, we'll talk about the causes of the issues of malocclusion and bruxism, anterior open bites, locked in occlusions, cross bites. Well, all of those are often so misunderstood. And wouldn't it be great to thoroughly understand it, and then be able to understand what it is when a patient comes to your office and has a crossbite and has pain, and we look at that and say, oh, and suggest from our training that there is a potential contributing factor to the pain, or the most significant contributing factor, when in fact the 15 other crossbites that we saw in the past month, there was no pain or dysfunction. It's how we were trained to look at this, and we need to reevaluate that training and understand what it is that may be at the heart of that discomfort, and how we can resolve it. And chances are we're going to be able to resolve it without orthodontic care. And I think that's the issue. or we can take patients who have been suggested that they have aggressive repositioning therapy or orthodontic care, and help them, guide them through a process that is much more reversible and much more conservative. This is for that patient that comes to your office with some kind of major concern. What about the patient that comes to your office that says, you know, I started clicking. I'm 17 years old. I just had my braces off 3 months ago, and now I'm starting to click. What should I do? Should we send that back to the orthodontist? What message does that send? Does that not send the message that says it's the orthodontist's fault? And is it? What's causing the click? Why are they clicking? What about the patient who occasionally locks? What causes that? How do we get them out of that? What's the best way and the most conservative way to do that? Is this something I can do in my general dental office? And the answer is yes. What about the patient who walks into, and in the discussion says that they wake up in the morning with suboccipital, low-grade suboccipital pain or headaches? Is that something that makes us think, why, how is that related to occlusion or occluding? And we'll talk about the Cato and Levine studies, and you'll begin to understand what the posterior cervical musculature has to do with bruxism, and how certainly, in my way of thinking, there is no one better and in a better position to help that patient than we as dentists. So recently, I was at McGill just last weekend, teaching a course in Montreal, and we did a pretest. And then after the 2-day course, we answered these questions, and without fail, there were 38 students there that weekend, and in the discussion afterwards, they were overwhelmed by the answers they gave as compared to the answers they now understood. Patients who deflect in protrusion will likely have some sort of internal derangement. True or false? A patient who bruxes at night with significant intensity is likely to develop severe TMD. True or false? It is essential to eliminate slides from CO to CR to prevent the likelihood of a patient to develop joint dysfunctions or facial pain. So the discussion of slides becomes very, very important in our seminars. Bruxism is caused by malocclusion, occlusal interferences, and may be associated with periods of stress. True or false? It is advisable to complete an equilibration on a semi-adjustable articulator mounted in CR before equilibrating clinically. We'll go into depth about the role of CR, the role of articulators in face bows. Bruxism is an attempt to open the airway and thus eliminate sleep-disturbed breathing will eliminate bruxism. This is now a common teaching in dentistry. Is it true? Is there a relationship between bruxism and apnea? If you eliminate the apnea, do you eliminate the bruxism? How are they related? I'll give you a hint. It's not simply God's way to open the airway. Patients who complain of an uncomfortable bite should have their occlusions carefully adjusted and evaluated to CR. I'll give you a hint there. If we begin to evaluate a bite on someone who says my bite is uncomfortable, you better not be married, because you may be sued for polygamy, because you're going to get married to that patient as well. So do we ignore that patient? Of course not. So what's the patient management? How do we evaluate that patient? How do we let that patient know that we care about their occlusion and their feelings, but the way their teeth come together may not be their essential problem? How do we do that? Following restorative procedures, it's necessary to have patients check their occlusion, check their occlusions carefully for the next few days and report any sense of abnormality to their bites. Stylomandibular ligament tendinosis is an injury of stylomandibular ligaments insertion and can be associated with dental pain in the absence of dental pathology. True or false? Acute disc displacement without reduction will often cause pain in the affected joint and deflection on opening towards the ipsilateral side of the lock. Dental contact during a swallow is an MIP, and thus even bilateral contacts on the swallow is important. Don't be fooled on that one. A patient with a deep bite will have posteriorized condyles in the fossa and thus more likely to develop an internal derangement. A myth commonly taught. EMG's activities of the resting muscles have been shown to have no relationship to muscle pain. It's essential in a patient's history that they be asked if they grind or clench at night. Adult patients with disc derangements and or degenerative disease will often have a canted mandible and an altered occlusion as a result of their altered joint anatomy. True or false? So, why I would love for you to attend. One, I'm coming all the way across the pond. You got to come see me. But more importantly, it'll change the way you think about each and every patient. Your occlusal, it will be the last occlusion course you ever take. I never understood why people needed an occlusion 2 and an occlusion 3 course. It makes no sense to me. 3, you'll understand joint pain and orofacial pain complaints in a clear and concise way, and a way to help you not only explain issues to your patients, but to be able to help them without fear of failure, which is the number one reason people say, I don't want to treat TMD. And I'm not suggesting that any of us treat TMD. What I'm suggesting is once we learn how things got that way and why they stay that way and how easy it is often to resolve, you would be shocked at how much you can help patients who have whatever TMD means. But wouldn't it be nice to understand a little bit more and understand why TMD itself has no real meaning? There are universal reasons we have varied success and happiness in our profession. And over the years, I found, over the years, I have found that there are many of us who are not quite as satisfied, as happy in our profession as we either claim to be externally or claim to be internally. We think we know why, and it's not unusual that in our discussions along these lines, because we go deeply into Miguel Ruiz's 4 agreements, and we talk about your relationships with your patients, and I can only tell you it's real. And our goal is, there's no other reason. At this point in my career, there's really no other reason. I have no other goal but to help you and to help those in my profession who possibly have gone through some of the very difficult times or are going through some of the very difficult times that I went through. I was lied to for many, many years. There isn't a flag on any TMD camp that I didn't carry and believe in. And there wasn't a belief system that I didn't hold. It took a real good kick in the butt from a dear friend by the name of John Remmers when I started studying sleep, and he forced me to start looking at the science of dentistry and what I was and how I was thinking, and it was eye-opening. And rather than make my life more complex or complicated, or my relationships with my patients more complex or complicated, or that the treatment recommendations, more complex or complicated. It made it simpler, much simpler. And it forced me to do something that I couldn't believe was happening to me, that I wasn't before. I didn't realize that I wasn't being as honest with myself and with my patients as I needed to be. I'm not saying you're anywhere near there. I don't know that. I am saying that it's so nice to be able to go into the office without an agenda. It's so nice to be able to be honest with patients and understand that there are things that are not understood, not to feel like we have to have all the answers when some of the answers aren't there. People are smarter than we give them credit for. They appreciate the honesty. And my goal is to take that burden off your shoulders and let you go in with what information you may not have had that gives you the power to be able to help people in ways that you couldn't help them otherwise, but in ways that make you really comfortable and not afraid to fail. We cannot accept responsibility for that which we can't control. Dentistry does that. We're responsible for every crown for the rest of their lives. We're responsible. We take things personally. How do we beat that? So I want to uncomplicate occlusion. I want to uncomplicate your life, and I really want this to make a big difference. And I'd love for you to be there. Matt.
Hi, Barry. Right, I'm just going to come back on again. Thank you for that, Barry. We've had it's been an exceptionally well attended webinar, which we very thankful for everyone spending the time to be on.
Do we have any questions? Did we have questions along the way? I wasn't paying any attention.
We didn't have any questions. Please do feel free. I'm going to keep an eye on it for just a few minutes while I just wrap up. If any of you got any questions, raise your hand. There are a couple raising. I think Heidi's got a question. I'll just come back to you in a second, Heidi. But just wanted to say before we leave, before we get on to questions, thank you, Barry, for that little webinar, a bit of a taster of what you're going to be speaking to all the UK dentists about. I've been in dentistry as a dental technician, maxillofacial technician for nearly 25 years, bizarrely. Working in many dental hospitals with maxillofacial consultants, and one of the areas that I've worked in was TMD and occlusal splints, and that's where my interest has come in there. And over the last 8 years, really, I've been listening to your seminars. It's cleared so many things up in my own mind, and it's got rid of so many of my own internal arguments that I had from listening to all the different camps. I mean, I'd listened to many different speakers, UK based, US based. Roth Williams was one of the big things that I was influenced by one of the orthodontists I work with, and it just seemed so ridiculously complicated, and it certainly busts many myths that I listened to and believed for many years. So I personally thank you for that. And I know for sure the dentists that have attended the courses have definitely thanked you for that. And thank you personally, I know certainly after the courses. So hopefully any of the guys that have not been on a course who have attended this evening would come along and have that kind of same experience as well. So thank you.
Thank you.
I think Heidi had a question. Heidi, I'm just going to unmute you for a second, just to see if you have got a question. Hi Heidi, can you hear us okay?
Hi, yes, I was just going to ask about details for the course, that's all. Okay,
great. We're going to send out a follow-up to this session this evening. I think there's been 30 odd people attend this evening, maybe 40-ish. I think some people have dropped in and out sometimes signal, and I think Barry alluded to that earlier on. Online courses are great, however, it never quite gets the one-to-one interaction of a session. So we're going to send out an email follow-up. I believe it'll be tomorrow morning. I'll just send you a link to the courses, and there'll be also a code that you can use, and it'll be a discount code if you want to attend one of the courses. And if you book it within a week, I think you get the discount on there. Okay, any other questions at all?
Well, the only question can't be about cost. It's not that really depressing.
Hey, it's difficult times in our Brexit years in the UK.
Well, we come to the United States where our economy is booming. Just ask our president.
Okay, guys. I think a few of you have dropped away now, but there's still a good few of you left. Have any of you got any questions at all? And I recognise a few familiar names on that list.
So let me ask you a question, Matt.
Yep.
Is there any of the true or false questions that raised an interest that somebody would like us to, in the few minutes remaining, to discuss just one of them? All of them are really fascinating, and many of them, I know you get the feeling, oh, he's looking for something special, something different, because it seems so obvious, and some of them really are. But was there any of them that raised an issue that was worth talking about for just a few minutes before we go?
Any questions there, guys? Any chance you can show us that? You had a couple of slides, didn't you, at the end, where you had the yes and no answer questions. For me, I mean, certainly for me, I spent probably 5 or 6 years working one-on-one with an orthodontist who was mad on getting the CR position right, getting this canine, this kind of unreachable goal, and beating herself up for years about
it's interesting. Johnson wrote an article, Matt. Johnson wrote an article, and in the article he wrote, in the journal article he wrote, there is no dental procedure that has eliminated more interferences from CO to CR than the redefinition of CR. Yeah. So if you're worried about the interferences, why adjust the bite? Just redefine CR.
Yeah. And again, there's so many. What I've sat as a technician right between the camps, and one's arguing one position is CR, one's arguing another position is CR,
right?
And how we reproduce that. So,
the question is here's another one. Think about this. So what is it? What do you tell the patient to do in order to put the condyle in CR? What's the first thing they have to do? They have to close. They have to tell their masseter and temporalis to contract and hold in a position that they never reach during function, and then we're going to determine that that's the right jaw position. It makes it. And what if there's a little fluid in the joint? Now the patient's sick because they're not in CR. I mean, there's and it drives and it's driven dentists crazy. So what we've learned is reproducibility is helpful for the dentist who's doing major restorations, but it has nothing to do with the patient's health.
Yeah. Totally agree. And I think that the dentists that we've been on call we've got a good long-standing relationship with, and it's almost like light bulb moments. And I think you allude to this in the seminars. You see light bulbs pinging constantly, where it might be just something really simple. The question about bruxisms caused by malocclusions. And then we start talking about.
So is that commonly, if we ask, I don't know the answer to this. So if we were to ask most dentists, I'm betting not the dentists that are here, because these are people that obviously have some interest in occlusion, or what's possible. If I were to ask most dentists, does malocclusion cause bruxism? Do you believe the answer would be yes?
Yep, the majority. Wow. So yeah.
Wow. Okay. Wow, that's disconcerting.
Yeah.
But we'll fix that.
Cool. We've got a few questions coming through.
Cool.
So we've got Jill Adams, who's just got a question there. I've seen your name for many years. I do feel we are still expecting to be God for joint pain. What percentage approximately are to do with us? Jill, shall we do? I'll just try and unmute you for a second, Jill, just to see if you want to ask any particular questions. And I know we've also got Alan Matthews, who we know as well. So we'll get back to your question in a second. Jill, can you hear us okay?
Okay, that's really scary.
Don't be silly, Jill. It's all good. It's all good.
Now I've got a nice glass of wine. I'm sitting here enjoying my evening, and now I'm on TV.
No,
Can't see me, can you?
No. Oh my God, Jill, you need to dress more appropriately.
You're so right. Okay, no, I enjoyed that. Admittedly, my alarm failed to go off, so I missed the first part of it. But I haven't seen your name for so many years. And my dog's going to join in. Yeah, thanks, Kelly.
Your dog is going to get my dog upset, just so you know.
But we do get patients coming in with this joint pain and going, duh, duh, duh. And when you pose those questions, I have to say I was hoping to hear some answers. Kelly. And they were, because often you go, at the end of the day, all I can tell you is stress. Do you feel that that is actually a relevant part of it? Because all we've got, when we refer into the NHS, all we've got is you have to have given them advice, and you have to have given them a device, you know, some sort of thing to stop them grinding before the NHS consultants will even look at them. So how are we as general practitioners meant to deal with that?
That's Jill. That's really interesting to me because you know, it's I've often, every time I go to England and I spend time with my English colleagues, I leave a little bit more scared about our you know, it's like our country is headed directly for single payer ourselves, and with those kinds of regulations being put on us by people who literally have clearly no clue what they're talking about, is sad. But we can work with those regulations because neither of those bother me. The question is what causes joint. So if a patient's got some effusion, some strain or sprain in the joint, what causes that? And what makes this joint any different, Jill, than a sprained ankle? So if we've got a sprained ankle, the first thing we do is we put patient in crutches, and we do some therapy on the ankle to relieve or reduce some of the inflammatory exudate and process. And this joint's no different. So what's important though is that we might tell that patient with a sprained ankle, no, you can walk gently, just don't walk aggressively and don't run and don't jump up and down on your ankle. Swim, do some non-weight bearing. So understanding what it is, what procedures, what steps up, what activities a patient does that truly loads load bearing on this joint it becomes important. How we can protect them from when they aren't protected becomes important, and what inflammatory steps we can provide for them becomes important. To suggest that stress, you know, do people grind or clench their teeth more in the presence of stress? The answer is people who tend to grind and clench their teeth, whether they have the phenotype or genotype to do that, are more likely to do more of it during stressful periods. But to simply say, well, it's just stress is silliness. And I can advise a patient that the stress may be at the heart of it, but it's not I'm not trained enough to resolve their stress. Hell, why should I resolve their stress when I've got my own to worry about? So I can advise them, but that's not really helping. That's just checking off a checkbox. So that I can say I did.
Everyone should be given a night guard, which is what we are being told to provide everyone.
Well, so the name of this seminar was what? Why night guards suck, and why the night guard that you tend to provide them is more likely has the potential to help them, and is more likely not to. And how can we design it so that it's more likely to help them? And that's exactly what we talk about. But it's not enough for me to just tell you that. You really have to understand what the force vectors and why the design is the way it is, and look at the science. And that's, Jill, that's exactly what we do. Come see me.
Thank you.
All right. Bring some wine.
Thanks for that question, Jill. I think we met at the.
We've met several times, yes.
Yeah, we have. You was on the British, no, the BSDSM.
Yeah.
That's it, yeah. Cool.
So we'll talk about that, Jill, because so there's a lot of myth about sleep and bruxism that we will address directly and show where the relationship is real and where it's not.
We're all slightly prejudiced against people across the pond, but no, that sounded very interesting.
Well, you've had Jill. You've listened to Mayor speak, I guess, at the
Few
BDA.
times, yes.
So Barry, I think Barry knows Mayor pretty well.
Yes.
Do you agree with Mayor? Oh, that's controversial.
Well, it's not controversial. Mayor, I mean, I can't say that Mayor's taken my courses. I can't say I've taken his. So I don't know what it is he's teaching. I have confidence in Mayor and think that the bulk of what he's teaching is evidence-based.
You're both good communicators. Thank you.
Thank you.
Yeah, Jill, having heard Mayor as well myself, it's definitely there's definitely you can tell he's taking Barry's courses for sure. Definitely. So.
He talks a lot about the ligament insertions, which we talk about, and the base, and my goal when a lot of the speakers, I'm not just saying, a lot of the current speakers in sleep started with my course, not because.
No, I think
it just happens that my course I started teaching him back in 2000 before people really knew, before I knew anything about sleep. I was teaching about it. Right from the beginning, we talk about evidence-based, and we won't teach anything. We'll teach what is evidence-based and what we know. Then we'll teach what we think, but we'll make sure that we make it clear this is what we think and that it's not known. We don't make theories up. That's unfortunately many of our gurus feel the need to know. And when in fact things aren't known, and that's because they don't have enough confidence to know what isn't known. We do.
That's good.
Great.
Thank you.
Thanks, Jill. Right, I've got one more question for Alan Matthews. I'm just going to mute you again, Jill. I'm just going to unmute Alan if he's got a question to ask. Hi, Alan. Can you hear us okay? I'm not sure how Alan can hear us just now. But Alan's question was, I don't know if you can hear this, but hi, Alan, how are you doing?
Not too bad. How are you?
Very good, thank you. Congratulations on your new job as well. All going well?
Thank you very much. Yeah, it's great so far.
Excellent stuff. So do you want to ask the question to Barry?
Well, I was thinking about things more from a kind of preventative standpoint, in that, you know, I might see people of a younger age who have what seems like a really aggressive constant click on any kind of movement, whereas maybe the kind of classic presentation is your 50-year-old plus woman who might have it. Now, my mother, I think, has a perforation of the retrodiscal tissue that's allowing a kind of bone-on-bone contact when she functions, which is really quite unpleasant to hear, but it's no longer causing her pain, although I understand that, you know, her bite might change if the condyle starts to wear over time. And I'm really keen to know, you know, should I be really worrying about young people who are exhibiting clicking? And are there ways that I can prevent other people from getting to that stage that it seems my mum's at?
If that's all really good questions. They are all really good questions. I will address them briefly, obviously, Alan, and tell you the following. One, let's talk about the youngster, because I want to save your mom. Your mom's really important to me. I know. I mean, that concept is really, really important because it's very common, and there's some reality and some myth to what we're taught. One, the youngster. We know that if there's clicking, we've got some compromise of the tethering of the disc. So there's been some trauma, probably to the lateral collateral ligament, the medial collateral ligament, etc. And we're starting to get these noises. And the question is how and why. So we know that there's a lot of macro trauma in youngsters, that there's a direct relationship with bruxism in terms of the microtrauma. And we know that some of these kids will outgrow it, some of them grow it and it'll come back. And some of it is related potentially to airway issues, which tends to get overstated, but is in fact a reality. So that, for their sake, my first thought is I just want to know if we're dealing with an airway issue, and we'll go into depth into that. The next thing is we don't want to overtreat. We don't want to make recommendations and start talking about occlusal changes in orthodontics for a youngster that may not need it. And the question is there something we can do for them for a short period to reduce the forces that allow what are these destructive forces to become forces to which they can adapt. If that posterior rim can adapt, despite being less well tethered, the noises will go away, and the disease process, the pathological process, will be in check. So the question is then, is there something we can do in a short period of time to decrease the forces, depending upon their age, their growth pattern, their growth state, where they are in the growth pattern? We can often construct what we call a pediatric B-split. And a pediatric B-split is something that is less likely to alter their growth and development, can in fact decrease the forces, allow that adaptation to take place, let that posterior rim, do you understand what I mean? So if that posterior rim is fibrocartilage, the disc is fibrocartilage, and if the posterior rim readapts, then the clicking actually stops, even though the disc is still not in quote unquote ideal positioning.
Like an adaptation of the retrodiscal tissue.
Sorry?
An adaptation of the retrodiscal tissue.
Well, we got to talk a lot about retrodiscal tissue. The retrodiscal tissue plays a role in your mom and not in that child. Your mom's situation is such that if in fact that retrodiscal tissue created what we call a pseudodisc, and then we perforate it and we've got some degenerative change, that's a real possibility. The issue of retrodiscal pressure causing the pain, remember, in that child, whether she's got pain or not, if she has pain, is probably not the retrodiscal tissue, because when you look at the force vectors never take that condyle up and back. If you look at the force vectors of the masseter and the anterior temporalis, it's going to be an anteriorization and anterior superior strain of condyle. And if you look at the glenoid fossa, you'll see the heavy trabeculation in that anterior superior section. So there's a lot of talk about the retrodiscal tissue that is invalid. So, but for your mom, that's a whole different issue. Trust me on this, I'd be less concerned about the occlusal changes of someone over 50 with slowly developed degenerative joint changes than I would be. It's amazing how well we adapt. Than I would be at a young person who's got juvenile RA or something like that. So those occlusal changes, one, we're going to really aren't all that important, and two, I'm not overly concerned with. I am concerned about doing something for a mom that decreases the forces that slows down degenerative joint changes. So we know that degenerative joint changes, the only way to deal with degenerative joint changes in any joint throughout the body is decreasing load. Stop weight bearing. So looking at when that weight bearing is occurring, controlling the weight bearing can go a long way for your mom.
So if we were to look at things like Lucia jig style devices that could feasibly decrease muscular activity, are there any concerns about the effect they might have on the joint?
No, because what you're referring to is a myth, just so you know. I don't like Lucia jigs per se. Lucia jigs don't follow the therapeutic protocol that we teach. But you're referring to if you change that, Al, to a well-designed anterior midpoint stop appliance following the therapeutic protocol, the answer is what we're taught is that lack of posterior support increases joint compression. We'll show you the May study. We'll show you why that isn't true.
Okay, thanks.
You got it.
Great stuff. Do we have any more questions from anyone? I think we've still quite a few people logged in, but if there's no more questions, I have posed it to the group. If there's no more questions, I'll say a massive thank you, Barry, for your time.
And thank you all for attending. I really appreciate you taking time out. I guess most of it over there and on the other side of the pond, and where it's a little darker than it is here now.
It's dark, it's cold, it's wet.
Don't tell me that. Don't tell me that. It's better be very nice in June. That's all I'm saying.
June's going to be spectacular.
Yeah. So we'll be in Sheffield on
the 21st of June. And then the week after, we're going to be in London at the BDA on the 27th and 28th. So the 27th.
That's a Friday, Saturday.
Thursday, Friday.
Thursday, Friday. Okay.
Thursday.
Gotcha.
So we'll have the hands-on session is day 2, and it's probably worth mentioning as well, if anyone's here, and obviously if they're listening back to the recording, I think every year you've been so far, there's the days have thrown up a patient or one of the delegates, and we've managed to help them. We had Neil who came along. Remember, we had the patient who'd been in pain for 25 years. But if you can remember that one, was it 2 years ago or something, 3 years ago?
But it raises a good point. If you're in Sheffield and you have and you're interested in coming, and either you have a problem with a joint or a long history of chronic facial pain or joint pain, or you are interested in the London course, and you have and you're in that area, and you want to bring a patient for us to take a history for and evaluate, and they've been willing to do that in a classroom situation, we would be and if it be you or a relative or a patient, all you need to do is contact Matt and get that information, and we'll review that, and if it's appropriate for us, we'd love to help.
Absolutely. Well, thank you again, Barry, and thank you for everyone who attended. If you're listening back, thank you ever so much again. We'll share this on Facebook and our usual channels, LinkedIn, so you can all have a listen back if you find it interesting. If any of you are interested again, we've got the courses. We're going to send out an email with everyone attending. We're going to send an email with a discount code to book on. And hopefully we'll see you in June, when the weather will be much warmer and drier, all being well. But the sun usually shines for the Glassmans, I think.
That's true. That is true. We've had some good weather.
It snows on your return. I think you've
right. No, it's October. In the middle of October, we come back to a storm that had us without power for a week. Yeah, that's right. Exactly. I don't think it's going to happen in July. I think we're good.
I think we're good. Great stuff. Well, thank you again. Have a great evening. Thank you so much. Bye now.